liver. Liver is a large solid gland. It is wedge shaped. Its color is reddish brown, soft or smooth in consistency, and friable in nature. And about the location, it lies in the upper right part of the abdominal cavity and occupies most of the right hypochondrium and epigastrium. About the lobes, liver has four lobes: right, left, quadrate, and caudate. And it has some supporting structures like right triangular ligament, left triangular ligament, and falciform ligament. About the blood supply, liver is a unique organ with dual blood supply. That is, it receives blood from the portal vein and the hepatic artery. Hepatic blood flow is around 1500 ml per minute, and of which portal vein contributes 80% and hepatic artery 20%. About the venous drainage, it is usually through three major hepatic veins: right, left, and middle, and it drains into the inferior vena cava. In lymphatic drainage, the superficial vessels drain into thoracic duct, hepatic nodes, celiac nodes, paracardial nodes, etc. And the deep lymphatic vessels drain into nodes adjacent to inferior vena cava or hepatic nodes and to celiac nodes. That is about the anatomy. Moving on to the disease as such, first we will discuss about liver abscess. So liver abscess is a common condition which is associated with higher morbidity and mortality, and early diagnosis offers best chance to cure the condition. When we see the symptoms, fever, chills, anorexia, abdominal pain, nausea, vomiting, weight loss, night sweats, diarrhea, etc. are the symptoms. And the signs: fever will be greater than 101 degree Fahrenheit, hepatomegaly will be present, tenderness will be there. It will be diffuse abdominal tenderness or tenderness in the right upper quadrant. Weight loss, jaundice, and ascites are the other signs. Next, about the types of liver abscess. Two types are there: pyogenic abscess and amoebic abscess. Pyogenic abscess caused by pyogenic organisms, and amoebic abscess is caused by the Entamoeba histolytica. Now, in detail about the types of liver abscess. First one, pyogenic liver abscess. So, focal infection within the liver can be divided into general categories. That is based on the pathogenic route by which the infecting organism is introduced into the liver. Based on that, the etiology can be classified under these headings like biliary tract diseases, bile phlebitis, hepatic arterial infection, direct extension of infection, and post-traumatic. Biliary tract diseases include cholangitis or total obstruction of common bile duct or suppurative cholangitis, which further lead to pyogenic liver abscess. In bile phlebitis, it is a thrombophlebitis in portal venous system that can be secondary to intra-abdominal inflammation, like in diseases like appendicitis, diverticulitis, infected hemorrhoids, inflammatory bowel disease. Secondary to these kind of conditions, there can be bile phlebitis, which further lead to liver abscess. And in hepatic arterial infection, systemic infections like endocarditis, pneumonia, osteomyelitis, these can result in bacteremia, and this further cause infection of liver through the hepatic artery. That's why it is categorized under hepatic arterial infection. The infection of liver is through hepatic artery. Next is direct extension of infection. That is from the contagious sites, means nearby sites like gallbladder, subphrenic space, etc. The infection will directly enter into the liver and can result in liver abscess. Then post-traumatic, that is after a trauma like penetrating and non-penetrating trauma to the liver will cause infection. That is the fifth category of post-traumatic. These are the different headings which can be given under etiology based on the pathogenic route. Next, about the causative organisms, as told, it is caused by gram-negative and gram-positive bacteria or anaerobes. It can include Escherichia coli, Klebsiella, Staphylococcus, Streptococcus, Proteus, etc. And about the clinical features, fever. And fever is the common symptom. Fever will be associated with chills and sweating. And the pattern is told like picket fence pattern. That is, as seen in the diagram, there will be a subsidence of the uh, rise in temperature. That is, there will be spike in the temperature in the afternoon or in the early evening. Then the temperature will return to the normal. So in a picket fence pattern, if the elevation of temperature is recorded, it will show a picket fence pattern. That is typical to the condition of pyogenic abscess. Fever related to pyogenic abscess will show a picket fence pattern. And next is pain. Pain will be present in the right subcostal or epigastrium. It can radiate to the right flank, or referral pain will be present in the right shoulder also. And then it is nausea or vomiting and anorexia. These are the main clinical features. And about investigations, as it is a condition of infection or inflammation which is present, of course we will go for WBC, that will be raised, then blood culture to identify the organism, causative organism, then liver function test, radiology, means radiology, if there is hepatomegaly and all, there will be raised diaphragm, pleural effusion will be present, then USD will give the accurate location of abscess, then CT scan also shows the abscess cavity, its size, the site, location, number, etc. So these are the investigations which can be suggested in the condition of pyogenic liver abscess. Next is the management. Management, both conservative and surgical management is told. And in conservative management with appropriate antibiotic therapy and prompt drainage. That is the conservative management tool. And antibiotics include broad spectrum antibiotics like metronidazole, ampicillin, gentamicin, synthetic penicillins, cephalosporins, etc. And once the culture and sensitivity report is available, then we have to go with the specific antibiotics. Depending upon the culture and sensitivity report, that have to be continued to 4 to 6 weeks. That is, a prolonged course of antibiotics have to be administered in this condition. Next is drainage. Both ways, percutaneous drainage and open surgery is advised. Drainage, we should not go for drainage if multiple small abscesses are present, or if the disease or if the patient is responding properly to the antibiotic therapy, then we should not go for drainage as such. Percutaneously, the abscesses may be drained under ultrasonography or CT control. That will be giving the better vision. And the route of surgical drainage depends on the position of the abscess. That is, it may be transthoracic, or transpleural, or transabdominal, or transperitoneal. Transperitoneal approach has advantages like it gives a clear view to the liver to detect any unsuspected abscesses, and it gives access to the biliary tree to exclude any cause there. So transperitoneal approach has clear advantages. And disadvantage of transperitoneal approach is that the abscesses situated in the superior or posterior surface are difficult to drain. An extraperitoneal approach may be done anteriorly or posteriorly depending on the size of the abscess. If the abscess is in the anterior or antero-inferior surface of the liver, incision is made anteriorly, just beneath and parallel to the costal margin. The muscles are incised, then fascia is incised, the parietal peritoneum is reflected from the inferior surface, and the abscess is reached and it is drained extraperitoneally. And if the abscess is posteriorly placed, the skin incision is made over the 12th rib. The rib is resected superiously and transverse incision made through the bed of the 12th rib, and the parietal peritoneum is reflected from inferior surface of the diaphragm, and thus the abscess is reached and drainage is done. That is the route of surgical drainage. One is transperitoneal and another one is extraperitoneal. Next is amoebic liver abscess. That is, the abscess caused due to Entamoeba histolytica. So here, the other names of amoebic liver abscesses, tropical abscess, dysenteric abscess, etc. And its incidence is marked, means it is predominant in males, and the age is like after second decade. It is one of the complication of amoebic dysentery caused by Entamoeba histolytica, and the common site of affliction is upper and posterior parts of right lobe of liver. That is the common site of affliction. So one thing, it is a complication of amoebic dysentery. So the patient will be having a history of dysentery, and next thing, the site will be upper and posterior parts of right lobe of liver commonly. And how it is, means how the infection is spreading. So the cyst of Entamoeba histolytica, that is consumed by human, and then in the small intestine, when it reaches, the cyst wall will disintegrate and the trophozoites are released, and this will enter into the colon, and through, if a colonic lesion is present, this Entamoeba histolytica will pass from the colonic lesion via the portal vein into the liver, or else it will invade the mesenteric vessels and then enter into the portal circulation, and in the liver it will cause hepatic abscess. And if at all there is a rupture of this abscess happening, then it will lead to other complications like empyema, pericarditis, peritonitis, and then through hematogenous spread, it will reach into the lungs, spleen, brain, and other important organs. So that is what is happening, or how the cyst will result in hepatic abscess formation. Cyst will consume by a man, then it will reach the small intestine, then from the colon it will enter into the portal circulation through the mesenteric vessels or the portal vein, and then it will form the hepatic abscess. The stages of amoebic liver abscess, it is told as two: amoebic hepatitis and amoebic abscess. Hepatitis, you know, inflammation of liver, and it is characterized by increased lymphocytes, infiltration, mononuclear infiltration, fatty changes, and lysis of hepatic cells will be happening in the first stage of amoebic hepatitis. And in amoebic abscess, the pathology happening is the amoeba will colonize the liver, and intrahepatic portal thrombosis and infiltration will happen, and there will be cytolytic changes in the surrounding structures, and these small necrotic areas will combine, and these small necrotic areas, when combined, it will form a large single abscess. So that is the next stage. So in the first stage of hepatitis, it is characterized by increased lymphocytes, mononuclear infiltration, lysis of hepatic cells, etc. And then in the second stage of amoebic abscess, the colonization of amoeba will happen in the liver, and as a result, cytolytic changes will happen in the surrounding structures, and small necrotic areas, coalescence, and it will result in the formation of large single abscess. And here the clinical features, as I have told, prior history of amoebic dysentery will be there. Then early symptoms like anemia, loss of weight. Then typical clinical features are fever, which increases at night, associated with liver pain. And below the right costal margin, there will be tenderness and rigidity. That is the main clinical features. And next is the character of pus in the liver abscess. So the pus present in the abscess will be a mixture of RBC, WBC, and broken down liver cells. And it is the amoebic pus is described as chocolate sauce or anchovy sauce. It contains staphylococci, streptococci, and E. coli. The investigations, first thing is blood examination. In blood examination, leukocytosis, anemia, liver function tests, these have to be checked. Then stool examination, amoebic stool will be present. Sigmoidoscopy can be done, and that will help in revealing the amoebic ulcers. Then aspiration of liver abscess, that have to be done for culture and sensitivity. Then radiography, serology, these are the other investigations which are suggested. And the complications, as mentioned earlier, if untreated, it bursts into the other cavities like into peritoneal cavity. If it is bursted, then amoebic peritonitis. Into the right pleural cavity, empyema. Into the right lung, bronchohepatic fistula, lung abscess, pneumonia, etc. So when it is not treated, it will burst open, and accordingly it will cause the complications depending on the region affected. Management, medical management, percutaneous aspiration and surgical drainage. Medical management, it is amoebicidal drugs like metronidazole 500 mg or 750 mg orally 1 TID for 5 to 10 days. Then other drugs like emetic, dihydroemetic, chloroquine, these also can be given. And next treatment means first was medical, next it is aspiration, percutaneous aspiration. So needle aspiration is indicated if after giving amoebicidal drugs also the condition is not subsiding, that is the amoebic abscess is persisting even after administering the amoebicidal drugs, or in the radiographic evidence it is clear uh, impression of that hepatic abscess is there, then also needle aspiration can be done. Then left lobe abscess, if it is present, then needle aspiration can be given. And to rule out pyogenic abscess, these are the indications for needle aspiration. About the technique of aspiration, a long needle with wide bore have to be used. Local infiltration of anesthesia is given. Then 9th or 10th interspaces, that is the preferred route between the anterior and posterior axillary lines. So through that the needle have to be inserted, and once it is reaching the abscess, the content or the pus have to be aspirated and should be, then post-operative normal precautions have to be taken. That is the technique of aspiration. About the Ayurvedic reference in Sustra Samvidhana Sthana 9th chapter, it is told Abhyandaran Atasthurtham Vidradin Parinat Adipyavaya Vyaya Pruthak Sambhuya Vadosha Kupita Gulma Rupinam Valmigavat Samunnatham Anta Kurvandi Vidradi Gude Bastimukhe Nabhyam Kuksha Vangshanayostata Brakayor Yakriti Plini Hridaye Klomni Vatadha. That is in detail about Vidradi you will be dealing in the next classes. So here just to understand that the condition of liver abscess can be taken as a correlation of Abhyandara Vidradi. So while explaining Abhyandara Vidradi, Acharya have mentioned the sthana like Vrkayor Yakriti. So Yakrit is one sthana told for Abhyandara Vidradi. So Abhyandara Yakrit Vidradi can be correlated as this liver abscess. In detail about Vidradi, you will be dealing in later classes. So, liver abscess, they are potentially lethal clinical entity, and if prompt diagnosis and treatment are not accomplished, the condition is fatal. As told earlier, it can lead to complications which can affect the other systems or other adjacent organs. So, prompt diagnosis and treatment is very essential, and early diagnosis and better management will help. That is about liver abscess. So mainly two types, pyogenic and amoebic. Pyogenic caused by pyogenic organisms, amoebic by Entamoeba histolytica. And clinical features are almost similar. Treatment is also one in pyogenic it is mainly about antibiotics, and in Entamoeba histolytica or amoebic abscess it is amoebicidal drugs. Other things it is almost similar, only the approach is different. Next is portal pyemia or bile phlebitis. As told earlier, it is an inflamed thrombosis of portal vein or infective suppurative thrombosis of portal vein. That is the condition, and it usually follows after severe infection of areas drained by portal vein. And causes are appendicitis, diverticulitis, or any severe abdominal sepsis. Nowadays, it is becoming rare because of availability of good effective antibiotics. Both preoperative and postoperative antibiotic administration is helping in reducing its incidence. And what is happening? Like infective thrombus in the vein, that is the vein draining the infective area, there will be formation of infective thrombus, and this infective thrombus will get dislodged as a infective emboli, and this will reach liver, and in the liver parenchyma it will cause multiple abscess, and thus resulting in pile phlebitis. E. coli is the most common organism. Often staphylococci anaerobes or combined infections can also be involved in this condition. Clinical features are high fever with rigors, toxicity, drowsiness, jaundice, tender soft liver, ascites, and investigation, blood culture is a useful investigation. Treatment, antibiotics. Antibiotics, combination of third generation cephalosporin, aminoglycoside, ceftazidime, amikacin, metronidazole can be used. Then IV fluids, blood transfusion, fresh frozen plasma, ventilator support. These are all according to the condition of the patient. Mortality is very high, and usually patients die of hepatic failure, septicemia, multiple organ dysfunction syndrome, etc. So it is better to prevent portal pyemia by prior good antibiotics in suspected cases. And treatment is treatment have to be given for the primary cause. That is very important. That is about portal pyemia. So once again, portal pyemia or pile phlebitis is a condition of inflamed thrombosis of portal vein. It usually follows after no.
Hello?
It usually no.
Ma'am, you can continue.
Okay. So portal pyemia does the inflamed thrombosis of portal vein usually follows after severe infection of areas drained by portal vein. Causes appendicitis, diverticulitis, or any severe abdominal sepsis. And now the incidence is rare because of availability of good effective antibiotics. And how the pathology is infective thrombus. That is from a vein draining the infective area, infective thrombus is formed. Later it gets dislodged as infective emboli, and then it reaches the liver, and in the liver parenchyma it causes multiple abscesses, finally resulting in pile phlebitis. Normal other usual features are present like high fever, rigors, drowsiness, jaundice, etc. Then treatment is antibiotics, IV fluids, blood transfusion, ventilator support, and treatment mainly is for the primary cause. That is very important. Next disease is hydatid cyst of liver. So hydatid cyst, the word meaning is dewdrop or watery vesicle. So it is a cyst, of course, and here the hydatid word itself means dewdrop or watery vesicles, and it is caused by Echinococcus granulosus. That is a dog tapeworm, a parasite. And how it is means how it is forming the hydatid cyst. How the life cycle is. The main host or the main causative organism at first is infected offal of sheep. Sheep is the intermediate host. So from the infected offal of sheep that is eaten by the dog, which is the definitive host, the Echinococcus granulosus is released. It develops inside the dog's intestine into a parasite of 1 centimeter long with a head and 3 segments. And this ova is expelled from the dog's intestine to grass and vegetables. And this eggs, again it is ingested by sheep, cattle or human beings. And then from there, through the portal vein, it enter into the liver in the larva form, and it forms the hydatid cyst inside the liver. It takes few years to evolve into a complete hydatid cyst, but this is the process by which this ova or this Echinococcus granulosus enter into the human. And about the pathology, it has got 3 layers. That's cyst. First is adventitia or pseudocyst, that is an inseparable fibrous tissue due to the reaction of liver to the parasite. That is the layer of adventitia. It is also called pseudocyst. Then next is laminated membrane or ectocyst. That is from the parasite itself. That is a whitish elastic and it contains hydrated fluid. And it can be peeled off readily from the adventitia. That is the next layer. Then it is the germinal epithelium. That is the only living part lining the cyst. And this layer secretes hydrated fluid, brood capsules and scolysis. Scolysis means heads of the future worms. So this is the pathology, how the cyst is formed. 3 layers: adventitia, laminated membrane and germinal epithelium. And about the hydrated fluid features, it will be clear, having high specific gravity, and inside the fluid there will be hooklets and scolysis. And once this brood capsules disintegrate, it forms into daughter cyst. So inside one mother cyst, so many daughter cysts will develop as a result of disintegration of this brood capsule. And how the disease progresses, what is the course of the disease? The parasite may die and cyst will eventually may get calcified. And commonly the cyst enlarges and it is palpable per abdomen. And it can cause complications like jaundice. Means when it is exerting pressure over the biliary tree, it can cause jaundice. Similarly, if it is getting ruptured and if it is rupturing into the peritoneal cavity, then it can cause anaphylactic reactions that can be like life-threatening shock, or such kind of complications can develop. Another thing is if it is rupture into biliary channels or rupture into bowel, pleural cavity, etc. So like that, the cyst the course of the disease will vary. In some cases, secondary infection will be happening to the cyst and which will lead to suppuration, septicemia, etc. Then another condition is where secondary cyst will develop in other organs like lungs, spleen, mesentery, retroperitoneum and other organs. Secondary cyst can occur. Another thing is, as a result of this hydrated cyst, there can be hepatic dysfunction or disseminated abdominal hydatidosis. Disseminated abdominal hydatidosis means the rupture of hydrated cyst into the abdominal cavity. So that also can occur as a result of that can be the final future of this hydrated cyst. So many ways the course of the disease will vary. Either it can die and the cyst will get calcified, or else it can form a secondary infection, or else it can rupture into different adjacent structures, or it can cause secondary cyst in other organs. And about the clinical features, asymptomatic palpable liver with classical thrill or hydrated thrill. Hydrated thrill, it occurs when a mother cyst, as I have told, inside a mother cyst, once the brood capsules is disintegrated, then daughter cells are produced. And when a mother cell is packed with unruptured daughter cyst, and when percussion is done over the place, then due to this consistency of this daughter cells and the tension of the fluid inside it, the cyst will make a vibration and produce a sensation of thrill. That is hydrated thrill on percussion. Due to the consistency of the daughter cells inside the mother cyst, there will be a vibration felt or a sensation of classical thrill will be felt. That is called hydrated thrill. So that is one clinical feature. Next is jaundice and pain. Then features of anaphylaxis. Then discomfort in the right upper quadrant area, dyspepsia, cachexia, weight loss, fatigue, vomiting. Then this condition can be associated with splenomegaly, pleural effusion, cholangitis, asthma, fever, etc. Then Camelot sign. Camelot sign is when there is rupture the cells will float like a water lily. That sign is called Camelot sign. That is also called as water lily sign. It is when there is detachment of the endocyst membrane, that will result in the floating of that membrane inside the cyst. That sign is called water lily sign or Camelot sign. And the complications of hydatid cyst are anaphylaxis, rupture, jaundice, as I have told. When it is compressing the biliary tree, it can cause obstructive jaundice. Then infection, secondary infections to other organs. Calcification, when the parasite die, the cyst can go for calcification. Then hepatic dysfunction, that is liver failure. They are the complications. And investigations, ultrasound, that is diagnostic. It reveals the daughter cyst, etc. If calcification is present in the cyst wall, that also can be revealed by ultrasound. Then X-ray also can help in showing the calcification. Then CT scan abdomen, that also help in accurate diagnosis in identifying the cyst, that can be made by CT scan. Then serological tests like ELISA, etc. can be given. Then secondary laboratory test, that immunoblotting, polymerase PCR, means polymerase chain reaction, such kind of test can be given. Then liver function test. Then another one is Cassoni's test, that is an intradermal injection, intradermal test which can be given. Then MRI, that when there is jaundice, to visualize biliary tree, its relation to hydatid cyst, that all can be revealed by the help of MRI. Then ERCP also help to find the biliary communication. These are the main investigations which can be suggested. So ultrasound, X-ray, CT scan, primary serological test like ELISA, secondary laboratory test like PCR, liver function test, Cassoni's test, MRI, ERCP. Next is the treatment. So treatment, first it is told about the drug therapy. So what are the indications and contraindications for drug therapy? Drug therapy can be given 10 days prior to intervention. That if we are planning to go for intervention, then also prior to that also drug therapy can be indicated. And after the procedure also for 1 month drugs can be given. Then inoperable cyst, where surgery cannot be done, in such cyst drug therapy can be given. Multiple or multi-organ cyst, their surgery is difficult. Recurrent hydatids, surgically unfit patients, cyst in lungs, these conditions drug therapy is indicated. And contraindications, large cyst, honeycomb cyst, infected cyst, calcified cyst, and in conditions of pregnancy, drug therapy is contraindicated. And the drugs used are, one is albendazole, that have to be given in a 4-week cycle. 4-week cycle, like 4-week cycle, the drug have to be given, and with the 2 weeks free interval. Drug free interval should be given for 2 weeks, and 4 cycles this drug can be given. It is ovicidal, larvicidal, and vermicidal, so it will act on this condition. Albendazole is the commonly used drug. And other drugs are praziquantel, mebendazole, etc. These also have the same, means they act on the parasites as such. So these are the drugs which are used in hydatid cyst. Then next procedure is PAIR, means PAIR, puncture, aspiration, injection, and reaspiration. That have to be done percutaneously. It can be done under USG or CT guidance. Under local anesthesia, cyst is punctured using a cholangiography 22 gauge needle through the thickest root or part of the cyst wall. Cyst is entered through non-dependent wall, and 50% of fluid is aspirated. All mother and daughter cysts have to be aspirated. Then radio-opaque dye is injected. That is done to see any communications are present. Scolicidal agents can be injected into the cyst, and after 20 minutes reaspiration is done. And a sclerosant alcohol is injected. If cyst is 6 centimeter or more, a drainage catheter can be placed for 24 hours for complete drainage, and later alcohol sclerosant is injected to completely uh, treat the condition. That is the technique of PAIR: puncture, aspiration, injection, and reaspiration. Puncture have to be made with cholangiography 22 gauge needle, then aspirate the fluid along with the multiple or daughter cyst, then injecting a radiopaque dye, then again that is done to detect any presence of communications, then again that is reaspirated. And if there is a cyst which is present, that is more than 6 centimeter, then drainage catheter can be placed. Other techniques like double puncture aspiration and injection, percutaneous evacuation of cyst, such procedures are also done. But PAIR has gained wide acceptance because it is safe, it is less invasive, and it is easier to do with low morbidity and mortality. So it is a procedure which has gained wide acceptance. That is about hydatid cyst. So hydatid cyst, it is caused by Echinococcus granulosus. That is a dog tapeworm. We have seen about the life cycle, and the cyst as such, it have got 3 layers: adventitia, laminated membrane, germinal epithelium, and this layer secretes the hydatid fluid, which is clear, having high specific gravity, and shows hooklets and scoliosis. Course of disease may vary. In sometimes the parasite can die and cause calcification. Sometimes it will rupture into the adjacent cavities. It can cause secondary infection to other secondary infection, resulting in separation and septicemia. It can produce secondary cyst in other organs. It can result in hepatic dysfunction, etc. Clinical features: one is hydatid thrill, then jaundice, pain, discomfort in the right upper quadrant, dyspepsia, weight loss, then Camelot sign. Complications: as told in the course of the disease, it can result in anaphylaxis, rupture, jaundice, infection, calcification, or liver failure. Investigation: USG, X-ray, CT, liver function test, Cassoni test, MRI, ERCP, all these can be suggested. And treatment: drug therapy, albendazole, praziquantel, mebendazole, etc. And other than that, means invasive techniques, it is PAIR, which is widely used. Other techniques are double puncture aspiration and injection, and percutaneous evacuation of cyst. Next is tumors of liver. Tumors of liver, first one is hemangioma. Hemangioma, you know, that is a tumor made of blood-filled cavities. That is hemangioma. When we consider the tumors of liver, they are the commonest benign tumor of the liver. It is usually solitary but can be multicentric. The compressibility of the tumor is diagnostic because hemangioma is blood-filled cavities, so it will show compressibility. That is a diagnostic feature for the condition. It is common in females in the 5th decade, that is in the ratio 3:1. Commonly they are asymptomatic. They can occur in right and left lobes. Calcification is seen in 10% cases. It is congenital in origin. Then it may compress over the gastroduodenum. So if it is compressing, as I have told, usually it is asymptomatic. But if it compress over the gastroduodenum, then it will cause abdominal pain and vomiting. Then if there is acute thrombosis, then pain, fever, and features of liver abscess that can be seen in the patient. Spontaneous rupture can occur, but it is very rare. Then about the investigations: LFT, AFP, CEA, these are the investigations suggested. And complication usually occurs if hemangioma is more than 8 centimeter in size. Needle aspiration and biopsy are contraindicated. UST, CT scan are confirmative. As it is a blood-filled it is a hemangioma which is means inside it is blood filled cavity. So if at all we are planning for a surgical intervention, we have to go for angiogram. We have to understand about the status of the blood vessels. So if we are going for surgical intervention, then angiogram is also advised. Then MRI, usual investigations like USG, CT, MRI, that is also can be helpful in the confirmation of diagnosis. About the treatment, radiotherapy means prior radiotherapy. Before that, hemihepatectomy means hemihepatectomy can be the treatment. So prior radiotherapy can be given to reduce the size, and then hemihepatectomy can be done. And surgery is done when size is large, when the condition is symptomatic, when there is a chance of rupture or any other complications are present, then surgery is indicated. That is about hemangioma. Then next is hepatic adenoma. They are common in females, 10:1 ratio. They present as a solitary nodular lesion in the liver. It is said to be due to the use of oral contraceptive pills. It is uncommon in males but can occur with androgen use. It can occur in males also. Then, as I have told, it is commonly solitary, but at around 20% of cases it can be multiple. And when there is presence of more than 10 adenomas, then it is termed as adenomatosis. Adenomatosis is a condition where more than 10 adenomas are present. That is adenomatosis. Then the presentation, commonest presentation is upper abdominal pain. Investigation suggested are AFP, alpha fetoprotein, that will be normal, but if there is malignant transformation, it will rise AFP. This hepatic adenomas might turn into malignancy, so we advise resection in this condition. Other investigations are USG, CT scan. As told earlier, if we are planning for resection, better to do an angiography because it is vascular. So angiography is also suggested if resection have to be done. Then other investigation is MRI. That is also an ideal tool. As told, surgical resection is the needed treatment. Then limited resection is needed, and better to do resection prior to pregnancy. And in adenomatosis cases, means when there are multiple cysts are present, then either hemihepatectomy or transplantation may be required if it is a condition of adenomatosis. Otherwise, if it is solitary, then we can go for surgical resection. And whatever the condition is, first thing, as it is due to the use of OCPs should be stopped. Oral contraceptive pills should be stopped. That is important in case of treatment. So that is about hepatic adenoma. Next is focal nodular hyperplasia. It is a benign condition of unknown etiology that is seen in females, and in this condition there will be focal overgrowth of functioning liver tissue. As the name suggests, there is hyperplasia, that is overgrowth of tissue. So in this condition it is overgrowth of functioning liver tissue with fibrous stroma support. It is a hyperplasia of liver containing all components of liver in disorganized pattern, and the incidence, it is 8 times more common in females, and it contains hepatic cells as well as Kupffer cells. Then it is the second most common benign tumor. It usually presents as solitary nodule, and it is considered as a harmless condition. Then the investigation suggested are CT scan, USG, etc. And the presentation, it is vague pain in the abdomen. Vague abdominal pain may be the presentation. In some cases, rupture and bleeding can occur. That is considered as rare. Usually, it does not require any treatment. In this condition also, OCPs, if the patient is using, then that have to be stopped. That is focal nodular hyperplasia. As the name suggests, there is hyperplasia, overgrowth of functioning liver tissue, or else it is the hyperplasia of liver containing all components of liver in a disorganized pattern. Presentation, it is a vague abdomen pain. Rupture and bleeding also can occur, but it is rare. Treatment as such, it does not require any treatment, but OCPs, if it is used, then that have to be stopped. So that were the benign lesions. Now it is primary malignant tumors of the liver, and among that, the three important or primary malignant tumors of liver are hepatocellular carcinoma or hepatoma or HCC, then cholangiocarcinoma and hepatoblastoma in infants and children. Cholangiocarcinoma is already dealt, and hepatoblastoma that occurs within 2 years of life. That is the age, and it is the most common primary malignant tumor of liver in children, and it is common in male child, and it is derived from fetal or embryonic hepatocytes. In this case, serum alpha fetoprotein will be elevated. CT scan is the advised investigation. Then as a treatment, it is highly sensitive to chemotherapy, and if it is resectable, it is the initial choice of therapy, and liver transplantation is also beneficial. That is hepatoblastoma in infants and children. This occurring in age group, that is within 2 years of life. Most common primary malignant tumor of liver in children, that too common in male child, derived from fetal or embryonic hepatocytes. Investigation, serum AFP and CT scan. Serum AFP will be elevated, and CT scan will show the vascular mass with calcification. And treatment is highly sensitive to chemotherapy, and if it is resectable, means according to the condition, if it is resectable, then that is the initial choice of therapy. Liver transplantation is also beneficial in the case of hepatoblastoma. Next is the hepatocellular carcinoma or HCC or hepatoma. HCC is a primary malignant tumor of the liver with hepatocellular differentiation. Its incidence is increasing. It's becoming the fourth most common malignancy worldwide. It is the commonest primary liver malignancy. But as in we take the case of liver, secondaries in liver are most common. Then only primary will come. So when we consider the primary liver malignancies, HCC is the commonest one. But in liver, secondaries is the most common malignancy. When we take the malignancies, secondary malignancies are more in liver. Then it is common in cirrhotics and hepatitis B and C virus infection. Then male to female ratio, it is 4:1. Right lobe is commonly involved. About the etiology, the factors which can cause hepatocellular carcinoma are aflatoxin B1, that is a product of fungus aspergillus. It is a powerful carcinogen. Then next is hepatitis B and hepatitis C viral infection. Mostly it is common in individuals who have chronic positive status for HBsAg and who are chronic carriers. In such persons, there is chance to develop. Then another one is alcoholic cirrhosis. That is also a co-carcinogen. Then Clonarchus sinensis infestation, smoking, hemochromatosis, that is iron overload. Then hepatic adenoma. When we discussed hepatic adenoma, we have told there is a chance of malignant transformation to that condition. So a person with hepatic adenoma can change to malignancy. Then other factors like environmental related chemicals like DDT, trichloroethylene, that is also considered as etiological factors for HCC. Then tannins, anabolic steroids, polyvinyl chloride, these also are included. About the pathology, it is highly vascular with indistinct margin. It is well demarcated by fibrous tissue. Hemorrhage and necrosis are common. And the types, one is hanging type of tumor. That is, the tumor is attached to the normal liver by a small vascular stalk. And always it is connected to a stalk, so it is very well resectable. Next is pushing type of tumor, that is large, well demarcated, and pushing type. From that, we can understand that it displaces the normal vasculature. That is the next type, pushing type. That is also resectable. And third one is infiltrative type. That is indistinct it is, and it will produce infiltration. So this third variety is considered as difficult to resect. These are the three types: hanging type, pushing type, infiltrative type. Hanging type, tumor attached to normal liver by a small vascular stalk. Pushing type, large, well demarcated, and displaces the normal vasculature. Hanging type and pushing type are resectable. Infiltrative type, it is indistinct and infiltrating, and it is often difficult to resect. Next is fibrolamellar variant of HCC, FLHCC, that occurs in younger age group. Instances equal in both sexes. It does not show any elevated levels of serum AFP, alpha fetoprotein. Then tumor marker for FLHCC type is increase in serum vitamin B12 binding protein and increase in neurotensin level. That is the tumor marker here. In other conditions, we have told about AFP, but here in this FLHCC condition, there will not be any elevation in the levels of serum AFP. Instead, here the tumor markers are serum vitamin B12 binding protein and neurotensin level. Both will increase in this condition. It is not related to viral hepatitis or cirrhosis. Left lobe is commonly involved. It involves lymph nodes more commonly than HCC. CT scan shows central scarring, fibrostomas with thin hyaline bands that will be typical in this condition, and it is fairly resectable. Next is staging, TNM staging. As it is almost similar to other, like T0 is no tumor, T1 solitary tumor without vascular invasion, T2 with vascular invasion or multiple tumors, then T3 multiple tumors more than 5 centimeter. T2 it was multiple tumors equal or less than 5 centimeter, and if the multiple tumors are more than 5 centimeter, then it comes to T3. T4 when the tumor is having direct invasion to adjacent organs, then that is T4, that is the tumor category. Then N nodes, N0 no regional lymph nodes are involved, N1 regional lymph nodes are involved. Metastasis, M0 no distant spread, M1 distant spread is present. That is the staging of HCC. Next, about the clinical features. One, painless mass in the right hypochondriac region, and associated with that there will be loss of appetite and weight. And on that palpation, liver will be hard. It can be smooth or irregular, and it will be massively enlarged. If it is associated with cirrhosis, as told in the etiology, if it is associated with cirrhosis, then that liver can be nodular. And acute presentation is not uncommon. That is, when the tumor undergoes necrosis and hemorrhage, then it can lead to acute presentation. Then when there is hepatic dysfunction, or when there is compression to the bile ducts, jaundice will be present. Then ascites, splenomegaly, features of portal hypertension, that also will be present in HCC. Then hepatic thrill, that vibration present in the percussion. Then fever, dull aching pain in the right upper quadrant. Then features of chronic liver disease like jaundice, dilated veins, palmar erythema, gynecomastia, etc. Then liver failure, means once the tumor replaces the functioning liver parenchyma, then it causes liver failure. Then if there is portal hypertension or portal vein invasion by the tumor, then gastrointestinal bleeding can also occur. Other paraneoplastic syndromes also can occur, like hypercalcemia, hypoglycemia, sexual changes like gynecomastia, as told earlier. Paraneoplastic syndromes also will be present in this condition. That is the clinical features. About the spread of tumor, three modes like lymphatic spread, blood spread, and direct infiltration. Lymphatic spread, it can spread to other part of liver through lymphatics within the liver to the lymph nodes in the porta hepatis and other abdominal lymph nodes later. Then blood spread to lungs, bones, adrenals often can occur, and direct infiltration to diaphragm and neighboring structures. That is the spread of the tumor. And investigation, ultrasound abdomen, very useful method. It shows the hyperechoic mass. Then the extent, tumor extension, etc. can be made out. Then CT scan will reveal the size, location, extent, vascularity, etc. And it helps to assess the operability. Then tumor markers, alpha fetoprotein, carboxyprothrombin protein. This also will help in the uh, assessment of the tumor. Then angiography means it shows the vascularity of the tumor, the arterial pattern of the liver, arterial pattern of the tumor. This can be revealed by CT angiography or celiac angiography. Then liver function test, contrast MRI or CT scan. Then MRI, ascitic tap means when ascites is present, then for cytology, ascitic tap have to be done. Then laparoscopic evaluation and laparoscopic USG is also useful for the proper assessment of the tumor. Then investigation related to hepatitis B and hepatitis C, as they are involved in the etiology. Investigations related to that have to be done. Then surveillance screening for risk group, surveillance screening. Then PET scan, bone scan for identifying the secondaries. These also can be done as part of investigation. So investigations mainly USG, CT, MRI, tumor marker, angiography as it is vascular, then liver function test, then ascitic tap. If ascites is present, ascitic tap for cytology, then laparoscopic evaluation and USG, hepatitis B and C investigations, PET scan, bone scan, and surveillance screening. These are the investigations. Then about the treatment, first is definitive treatment, and when the condition is limited to one lobe, hemihepatectomy can be done. That is removal of 70% of liver that is compatible with life. That is hemihepatectomy. Laparoscopic resection is becoming popular now. Then in cirrhotic patients with HCC, it is advised total hepatectomy, that too with orthotopic liver transplantation. Orthotopic liver transplantation means two kinds of liver transplantation. It's orthotopic and heterogeneous. That is, orthotopic means complete removal of the recipient's liver is done, and a new or a donor's liver is placed in the position. That is called orthotopic liver transplantation. It is not part of liver which is transplanted, or it is not like keeping this recipient's donor, the donor's liver is placed. It is like completely removing the recipient's liver, the donor's liver is placed in the position. That is called orthotopic liver transplantation. Complete removal of recipients. Recipients means the patient's liver is completely removed and the donor's liver is placed. Other variety, what happens is we will keep the patient's liver, and in some ectopic place the donor's liver is placed. That is the next type. So here it is complete removal of patient's liver because it is a condition of cirrhosis. So this is advised in patients having cirrhosis along with HCC. Their total hepatectomy with orthotopic liver transplantation is required. Next is adjuvant therapy, that is systemic chemotherapy using intravenous adriamycin, cisplatin, carboplatin. Such drugs can be given. Then octreotide is useful along with other chemotherapeutic agents. It decreases the size of the tumor. Then neoadjuvant chemotherapy is also practiced to increase the operability or resectability of the tumor. That is, preoperatively, neoadjuvant chemotherapy is suggested. Then few newer treatments are tried using tamoxifen, interferons, EGFR antibody, interleukins, etc. And palliative treatment include radiofrequency ablation, that is, thermal ablation of the tumor by passing 18G needle into the middle of the tumor and passing electric current of 500 hertz. That is the procedure of radiofrequency ablation. Thermal ablation is done to the tumor by passing a needle of 18 gauge, and then electric current is passed through the needle. That is the radiofrequency ablation. Other techniques are percutaneous ethanol or acetic acid injection. That is also minimally invasive and can be injected using fine needle, and it is cheaper also. Then transarterial chemotherapy using adriamycin, cisplatin. Earlier told drugs can be used, and that can be done through gastroduodenal artery, transarterial chemotherapy. Then transarterial embolization using gel form, microspheres, gelatin sponge, etc. Transarterial embolization also can be done. Then chemoembolization, that is TACE, that is TAE, transarterial embolization, when it is combined with chemotherapy, that is called TACE. That is another palliative treatment. Then microwave or cryoablations, then ligation of hepatic artery. As it is considered that the tumor tissue is getting blood supply from hepatic artery, ligation of hepatic artery can be a good palliation. Then transarterial iodine lipiodol microspheres, targeted iodine I-31 with lipiodol injection. These also can be acting as palliative. Main treatments are, first is radiofrequency ablation, then percutaneous ethanol injection, then TAC, TAE, TACE, then microwave cryoablations, ligation of hepatic artery. These are the main palliative treatments. Next is the secondaries in the liver. So as I have told, when we consider the malignancies in liver, the commonest one is secondaries. Commonest malignant tumor in liver is secondaries in the liver. But when we consider the primary secondaries, HCC is the commonest one. That is the difference. So secondaries in the liver, it is the commonest malignant tumor in liver, and its incidence, not the incidence. Primary is to secondary, it is 1:20. That is the incidence of primary to secondary in the liver, 1:20. And the causes are divided into two, abdominal and extra-abdominal. Abdominal causes include carcinoma in stomach, colon, pancreas, small bowel, kidney, abdominal esophagus, rectum, and carcinoids. Then extra-abdominal includes melanoma, carcinoma breast, carcinoma lungs, carcinoma thoracic esophagus, carcinoma bladder, carcinoma prostate, testicular and adrenal tumors. So such kind of tumors are included under the extra-abdominal causes. So causes of secondaries in liver are divided into abdominal and extra-abdominal. Commonly secondaries in liver are multiple in one lobe or in both lobes. It can be solitary, but it is rare. That is about secondaries in liver. Next, it is the classification. Classification mainly colorectal, neuroendocrine, non-colorectal and non-neuroendocrine. That is the classification. Colorectal carcinoma, in relation, it has got special interest in relation to its secondaries in liver. It carries good prognosis. Secondaries can be synchronous or metachronous. Synchronous and metachronous we will deal in the next slide. For colorectal condition, investigation suggested are PET scan, then CEA, and the treatment suggested is resection, chemotherapy, intraarterial chemotherapy, etc. The therapeutic modalities. Colorectal liver secondaries show good prognosis when secondary are solitary. And next is neuroendocrine. Neuroendocrine, it includes gastrinoma, glucagonoma, somatostatinoma, non-functioning neuroendocrine tumors. These can cause liver secondaries, and this kind of liver secondaries are included in the category of neuroendocrine. So first was colorectal, next is neuroendocrine. And these tumors, neuroendocrine tumors, are slow growing, and the main symptoms are often due to secreting peptides, and that will cause different clinical symptoms. According to the secreting peptides, the symptoms will also differ. And investigation, hormonal assay, CT abdomen, CT angiogram, this can be suggested. And therapy or the treatment, hormone controlling therapies. It is an endocrine related tumor, or it is an endocrine related pathology. So hormone controlling therapies, chemotherapy, then liver resection, these are the treatment suggested. That is the second classification. First was colorectal, second is neuroendocrine, and third is non-colorectal and non-neuroendocrine. These are aggressive primary tumor causing liver secondaries, like from stomach, pancreas, small bowel, esophagus, gallbladder, urinary bladder, prostate. So from these kind of structures, when the liver secondaries are produced, they are included under non-colorectal and non-neuroendocrine classification. They carry poor prognosis. Treatment is chemotherapy, means early primary. If it is in stomach, then in that case and all, liver resection also can be done, but according to the condition. Overall, it is considered as a poor prognosis category. So that is the third classification, non-colorectal and non-neuroendocrine. And other classifications are there, like precocious, synchronous, and metachronous. Precocious means secondaries are presented or secondaries are identified before primary is suspected, like in carcinoid, colorectal cancer, etc. That is precocious. That is the condition of secondary carcinoma or secondary malignancy is identified before the primary is suspected. Next is synchronous. Synchronous means, as the term suggests, both primary and secondaries are identified at the same time, like in carcinoma stomach. Metachronous means secondaries develop much later, maybe long time after the treatment for primary. Then only the secondaries will develop. That is a condition called metachronous. That is the third classification. Precocious, synchronous, metachronous. Precocious, secondaries are identified before primary. Synchronous, both primary and secondaries are identified at the same time. Metachronous, secondaries develop much later, even after the treatment of primary, the secondaries will be developing. That is metachronous. Next is the route of spread. Route of spread can be direct spread, like from stomach, colon, gallbladder, etc. It can be hepatic artery. Through hepatic artery, the spread can occur, like in melanoma. Through portal vein, like in GIT malignancies, carcinoid tumors, etc. Then lymphatic spread from the breast, lungs, etc. It is through lymphatic spread. That is the route of spread: direct, hepatic artery, portal vein, and lymphatic. About the clinical features, they are multiple, hard, nodular, with nodule showing umbilication. Umbilication means there will be a depression in the middle, like that of the umbilicus, and that is due to central necrosis. That will be the clinical feature. Then, according to the extent of liver involvement, patient may have jaundice, loss of appetite, loss of weight, ascites, then pain in liver secondaries. Means when it is due to stretching of the liver capsule or due to tumor necrosis, there will be pain in liver secondaries. Often pain may be of primary tumor also. Next is rectovesical secondaries. Rectovesical secondaries, it is told like Bloomer shelf, that is thickening of the pouch of Douglas. Means as a result of this malignancy, there will be thickening of the cul-de-sac of Douglas or pouch of Douglas. There will be thickening, and that is called Bloomer shelf, and that sign is elicited during perrectal examination. That is rectovesical secondaries. It can be suggested by the presence of Bloomer shelf sign. Next is supraclavicular lymph node enlargement, that is Virchow's node enlargement, that is called Troisius sign. These are the clinical features. And other features like features of primary tumor, that is when stomach is involved, there can be vomiting, visible gastric peristalsis, palpable stomach mass. When it is colon which is having primary tumor, then there will be constipation or diarrhea, palpable mass, features of obstruction. So similarly, the clinical features according to the primary tumor will be also present. Investigation, primary can be identified by gastroscopy, colonoscopy, contrast X-ray, CT scan, etc. If primary is not identified by any of these methods, then we can go for liver biopsy, then liver function test, ultrasound abdomen, tumor marker, MRI, CT scan, laparoscopy. These are the investigations suggested. First, it is the primary which have to be identified, and if primary is not identified, then go for liver biopsy and other investigations like LFT, USG, tumor markers, MRI and CT. The treatment, chemotherapy is the treatment of choice. Surgery has a definitive role in primaries from colon or kidney. That is, if the primary growth is in the colon, then a palliative hemicolectomy is done. Along with that, if a solitary secondary is present in the liver, that can be resected. And if secondaries are in single lobe, then hemihepatectomy also can be done. Palliative procedures for other primaries are like for carcinoma stomach, palliative partial gastrectomy; for carcinoma pancreas, triple anastomosis or ERCP stenting. That are the palliative procedures for other primaries. And depending on the site of primary, drugs will vary. And for carcinoma stomach, mitomycin, 5-FU, etc. are given. For carcinoma colon, 5-FU, oxaliplatinum, EGFR antibodies that can be used. Then another procedure is hepatic artery ligation or therapeutic embolization, that is to relieve the pain. Then intraarterial chemotherapy is also tried, but that is having little success only. That is the treatment. Then methods other than resection, that is other to ablate the tumor, other methods which can be helpful are microwave therapy, radio frequency ablation, laser hypothermia, ultrasound or electrolyte therapy, as told in the earlier condition, like thermal ablation, etc. Same can be advised. Other than resection, these are the procedures which help to ablate the tumor. Next are liver cyst. Among that, congenital liver cyst, first is simple liver cyst. That is it is common in males. It is 3% common. The solitary simple cyst is congenital, and it is thin bluish walled cyst in one or other lobe containing clear fluid. Simple cyst will never communicate with the biliary system, and if communication is found, it will be cystadenoma. And the presentation, abdominal pain will be there. Hepatomegaly also can be there. Jaundice may be present in some cases. And the investigation suggested USG, CT scan, MRI and aspiration. Treatment, aspiration with sclerosing therapy, and then deroofing with partial excision of the cyst. Then laparoscopic or open method, that can be deroofing can be done by laparoscopic or open method. Then another one is complete excision. These are the treatment procedures. One is aspiration, next is deroofing, and third one is complete excision. That is the treatment for simple liver cyst. Next is polycystic liver disease. That is an autosomal dominant condition associated with polycystic kidney disease, and it arises from biliary epithelium. It does not communicate with biliary system. They are asymptomatic. If at all symptoms are present, that will be hepatomegaly, pain abdomen, jaundice and portal hypertension. Then investigation suggested USG, CT, MRI, etc. Treatment is percutaneous aspiration with sclerosing injection, then deroofing of all cyst, resection, liver transplantation, etc. depending on the condition. Next is neoplastic liver cyst. They are acquired cyst, common in females. They attain large size, multiloculated with papillary projections will be present. 10% of these neoplastic cysts are malignant. The neoplastic liver cysts include cystadenoma and cystadenocarcinoma. Cystadenoma is benign, containing mucinous or bilious fluid. Cystadenocarcinoma is that which contains hemorrhagic fluid. About hepatobiliary or hepatic cystadenoma, as told, it is benign and it contains mucinous or bilious fluid. It is septated, multiloculated, whereas if the cavity contains debris, it suggests malignancy. It is surrounded by smooth and thick fibrous capsule, and internally it contains septations or papillary projections are present inside. Investigation suggested MRI, USG, CT scan, ERCP. Treatment is enucleation of the entire cyst with surrounding rim of the normal liver tissue. Hepatic resection is also advised in this particular condition. But aspiration, deroofing, partial excision, sclerotherapy, these are not done in this condition of hepatobiliary cystadenoma. Next is hepatic cystadenocarcinoma. It presents as a large, palpable, smooth liver with abdominal pain. It carries better prognosis than HCC or cholangiocarcinoma. It can be cystadenocarcinoma arising from pre-existing cystadenoma, as we have told. Means that cystadenoma can change into cystadenocarcinoma, or it can present with malignant features. So that is one. And next one is cystadenocarcinoma without mesenchymal stroma. And here in this case, resection is the treatment and it carries good prognosis. Next is traumatic liver cyst. It is an acquired cyst of liver after liver injury in a blunt abdominal trauma. The biliary duct which is injured will cause bile leak into the existing intrahepatic hematoma, causing mixture of bile and blood. Cyst is pseudocyst in liver without an epithelial lining. It may resolve spontaneously or it can cause abdominal pain, jaundice, etc. and it may present months or years later. Investigation suggested are CT scan, and while taking history, there will be a history, old history of liver trauma. Then MRI is also helpful in diagnosis. Treatment is conservative, often deroofing or cyst excision with ligation of biliary duct. That will be needed. That is the treatment, because when there is connection with the biliary duct, there can be mixture of bile and blood. So for that, ligation of biliary duct is also needed as a treatment. Next is portal hypertension. It is the sustained elevation of portal venous pressure more than 10 mmHg. Normal portal venous pressure is 5 to 10 mmHg, and when this portal venous pressure is more than 10 mmHg, more than 10 mmHg is called portalation of hepatic venous pressure gradient greater than 5 mmHg. And the causes, it is increased portal resistance, altered portal blood flow. Increased resistance may be pre-sinusoidal, sinusoidal and post-sinusoidal. Pre-sinusoidal means it includes extrahepatic and intrahepatic causes like extrahepatic like portal vein thrombosis or splenic vein thrombosis, intrahepatic sarcoidosis, congenital hepatic fibrosis, primary biliary cirrhosis. These are the intrahepatic causes. Sinusoidal causes includes cirrhosis, hemochromatosis, Wilson's disease, non-alcoholic steatohepatitis, etc. Post-sinusoidal includes Budd-Chiari syndrome, constrictive pericarditis, veno-occlusive disease, etc. Next is the sites of portosystemic collateralization. The sites of portosystemic means there is an abnormal connection is present where lower end of esophagus, umbilicus, lower end of rectum, retroperitoneum and bare area of liver. These are the sites where portosystemic collaterals are present. Lower end of esophagus, that is present between the left gastric and short gastric veins with azygos veins, and umbilicus between paraumbilical vein and anterior abdominal vein. Then lower end of rectum between superior hemorrhoidal vein and inferior middle hemorrhoidal vein. That is the connection. These are the sites of portosystemic collateralization. Clinical features, main clinical features, the triad is esophageal varices, splenomegaly, ascites. Other features include jaundice, features of encephalopathy, recurrent infection, coagulopathy, hepatorenal syndrome, etc. Um, Features of encephalopathy means memory loss, altered behavior and mental status, the unconsciousness. These are all come under features of encephalopathy. Then investigations, blood investigations like HB, anemia can be present due to bleeding, nutrition suppression, etc. Then thrombocytopenia, leukopenia, this also can be present in blood. Liver function test will be altered. Then AFP and other relevant markers, renal function test, ultrasound abdomen, contrast CT MRI, MR venogram, hepatic venous pressure gradient, that is the gold standard to diagnose portal hypertension, HVPG. Then esophagogastroscopy, liver biopsy, ascitic tap, transient elastography ultrasound based, then splenoportography. These are the other investigations that will be useful in this condition. Management of portal hypertension, general measures, anemia have to be corrected, nutrition supplementation have to be given, injection vitamin K, bleeding condition will be there, blood and blood product transfusion also required. Specific measures according to the symptoms or according to the consequence, that is treatment of esophageal varices, prevention of hepatic encephalopathy, treatment of ascites, then measures to reduce portal pressure like surgeries, tips, then drugs to reduce portal pressure, then liver transplantation. These are the measures to reduce portal pressure. So according to the cause or according to the presenting symptom, treatment have to be specified. That is the next method. So this is the treatment, general measures and specific measures. That is about portal hypertension. So once again, portal hypertension is a condition where there is sustained elevation of portal venous pressure, that too more than 10 mm Hg, or else it is defined as elevation of hepatic venous pressure gradient, HVPG. And cause, it can be due to increased portal resistance or altered portal blood flow. Increased resistance can include pre-sinusoidal, sinusoidal or post-sinusoidal causes. Different sites of portosystemic collaterals are present, like lower end of esophagus, umbilicus, lower end of rectum, retroperitoneum and bare area of liver. Clinical features, the triad of portal hypertension include esophageal varices, splenomegaly and ascites. Other features include jaundice, features of encephalopathy, recurrent infection, coagulopathy and hepatorenal syndrome. Investigations, blood investigations, liver function test, tumor markers or relevant markers like AFP, renal function test, ultrasound abdomen, CT, MRI, venogram, HVPG, esophagogastroscopy, liver biopsy, ascitic tap. So these are the investigations. Management, general measures and specific measures. General, anemia have to be corrected, nutrition supplementation should be provided, injection vitamin K, blood and blood product transfusions. Specific measures specific to the cause or the symptom, treatment of esophageal varices, prevention of hepatic encephalopathy, treatment of ascites and the measures to reduce portal pressure. Next is Budd-Chiari syndrome. It is a syndrome or a group of disorders caused by occlusion of major hepatic veins or inferior vena cava or both at or near the level of hepatic vein ostia. That is, in simple terms, if we tell, there is an occlusion caused to the occlusion or the hepatic veins are blocked or narrowed by a clot. That is the condition of Budd-Chiari syndrome. Usually 3 major hepatic veins were involved by thrombosis or block, and it is common in females. Investigations suggested are transcutaneous Doppler, CT, and treatment anticoagulation or thrombolysis. As the cause itself is clot formation, we have to treat the cause, that is anticoagulation or thrombolysis. Then transarterial meatotomy. Transarterial meatotomy, that is in membrane obstructing IVC. A cut is to be made, that is called transatrial meatotomy. Then mesoatrial shunt between right atrium and SMV to bypass the occlusion. Then TIPS or IVC stenting or liver transplantation is also helpful. That is about Budd-Chiari syndrome. So Budd-Chiari syndrome is a syndrome or group of disorders caused by occlusion of the major hepatic veins or inferior vena cava or both. It is common in females. Clinical features depending upon the severity, that is in acute form it can cause nausea, vomiting, severe pain in right hypochondrium, etc. In less sudden onset it will be a development of ascites, edema feet, hepatic coma, etc. In chronic type there will be hepatic cirrhosis, ascites, esophageal varices, infection, etc. That is the clinical features. Investigations: transcutaneous Doppler, CT. Treatment: anticoagulation or thrombolysis, transatrial myotomy. A cut is made if there is membrane obstructing the inferior vena cava. Then mesoatrial shunt. Then IVC stenting, TIPS or liver transplantation. Next is the liver injury. Liver injury, can be caused due to blunt injury, stab or gunshot injury. It is the most common organ injured in blunt abdominal trauma. Types when we see, it can be contusion, laceration, avulsion, or extension into the thorax and biliary tree may be associated with other organ injuries like injury to spleen, kidney, duodenum, bowel, inferior vena cava, etc. There can be extended injury to the liver also. Then clinical features of shock means there will be torrential bleeding when there is liver injury, and that can lead to features like pallor, hypotension, tachycardia, asphyxiation, etc. And then distension of abdomen with dull flank, guarding, tenderness, rigidity, oliguria, tachypnea, respiratory distress, cyanosis, and hemoperitoneum, that is rupture of right lobe is more common than left lobe and leading to hemoperitoneum. Then hematoma will be formed, localized hematoma, which will later form into abscess. Then bile leak, if the biliary tree is injured, then bile leak will be there from the injured side, and that can lead to biliary peritonitis. These are the clinical features. Investigations: chest x-ray, US abdomen, CT scan, peritoneal lavage, HB percentage, PCV, coagulation profile, thromboelastography, arteriography, means to visualize the bleeding branch or bleeding vessel. These kind of investigations can be suggested. Treatment: general measures, it is IV fluids, blood transfusion, fresh frozen plasma, then bladder catheterization to know the, means as there is a chance of shock and all, we have to know the urine output. So for that, bladder catheterization. Then administration of factor 7, proconvertin, is also helpful in treatment. And the conservative non-operative management, as told, replacement of lost blood, that is the main thing. Then chance of infection is high, so prevention have to be done. Then important investigations or parameters have to be monitored regularly. Then to prevent the bleeding, to increase the success rate of this non-operative therapy, angiographic embolization can be done. Intensive care unit management for 2 to 5 days. Then CT have to be repeated, bed rest have to be continued, and patient can be back to normal activity only after 3 months. That is the initial conservative non-operative management. Specific treatment include push, plug, Pringles manner, and pack. Push means direct compression, means by the part of the liver which is injured, there direct compression have to be done, that is called push. Then plug, plugging the deep tract injuries using silicone tube or SB tube. Then Pringles manner to control bleeding on table, that is from hepatic artery and portal vein, there will be heavy bleeding, so that have to be temporarily occluded by fingers or using clamps that have to be occluded, that is called Pringle manner. That is the third one. And pack, that is the liver wound is directly packed with mop. These are the specific treatments to control the bleeding. Next it is laparotomy with thoracoabdominal incision or bucket-handle abdominal incision. Then small liver tear if it is present, then that can be sutured. Then, as I have told, next is Pringle manner, which is explained. Tractotomy. Tractotomy means bleeding vessel, the ligation of bleeding vessel individually on the cut surface. That is needed, and that is called tractotomy. Ligation of bleeding vessel individually on the cut surface. Then mesh hematography. Mesh hematography means liver can be wrapped with absorbable mesh. That is also to achieve hemostasis. Mesh hepatography. Then management of other organ injuries means don't concentrate on the liver injury alone, because we have to check for other source of bleeding if at all it is present. So proper management should be done to other organ injuries accordingly at the same time. Then post-operatively, patient requires ventilatory support, blood transfusion, electrolyte management, antibiotics. All these have to be provided. That is about the diseases as such. Next, it is the tips which was repeated in the treatment section. That is transjugular intrahepatic portal systemic shunting. It is a radiological procedure. It is an alternative method of controlling acute bleeding. So here it is mainly indicated in gastric varices where there is profuse bleeding. This is indicated, and it is also indicated in patients who have had recurrent bleeding. Means after doing medical or endoscopic management, still if there is bleeding, then this treatment procedure is advised. The procedure is a needle is passed through the liver. You can see the image. A needle is passed through the liver parenchyma into the portal vein and followed by dilation of the tract. And once the tract is dilated, a metal stent is placed. And then the stent is then dilated to achieve a portal to hepatic vein gradient. That is the procedure of TIPS, transjugular intrahepatic portal systemic shunting. First of all, a needle is passed through the liver parenchyma, then it have to be dilated, and after dilating, a metal stent is kept, and that also was dilated. Next is surgical shunt. That is another procedure which was repeated, and the aim of surgical shunting is threefold. One is to reduce the portal venous pressure. Next is to maintain hepatic and portal blood flow. Then to reduce or to not to complicate the hepatic encephalopathy. These are the aims of surgical shunting. Depending on the connection made, it is of different types, like portocaval, total portal systemic, like portocaval shunt, mesocaval shunt, splenorenal shunt. That is, a connection is made. Portocaval means portal vein and inferior vena cava. Then mesocaval means mesenteric vein and inferior vena cava. Splenorenal or splenic vein and renal. So that is the connection which is made to control the bleeding or to compensate, to shunt the blood flow. That is what is happening here. So these are the main treatments told for diseases of liver, which is repeatedly told. TIPS and surgical shunt, transjugular intrahepatic portal systemic shunting and surgical shunt.